this is part of our elective. And we also teach pre-meds, and we're going through cases and working with the New England Journal of Medicine illness scripts as well.
Oh, amazing. That sounds so fun. Okay, what is your favorite thing to do outside medicine?
I really like to play board games.
Yeah?
Yeah.
Ooh. Okay, what's your favorite board game? This is
like the classics. So I am absolutely terrible at Risk, but I love playing it. I love playing it, and I lose every time, but it just makes me want to play it more.
Does that tell you anything about like your actual risk tolerance in the world? Because I have no idea how to play Risk.
I think it's just more a matter of, can you be cutthroat?
And so you're telling me that you have a hard time being cutthroat, which I will support and reinforce and say that's probably a very healthy way of living. So may you lose many a Risk game in your life.
Well, thanks.
Of course. Antonio, hello. Do you want to introduce yourself to the crowd?
Yeah. Hi, everybody. I'm Antonio. Like Rochelle stated, we're both at LeComp Region 10. I'm currently applying for internal medicine. I just finished my last interview, so pretty excited about that. Yep, and that's pretty much it. Interested in critical care and maybe infectious disease, so we'll see how it goes.
That's incredible. Usually those are at the opposite ends of the spectrum, given the DX focus of ID and the RX focus of critical care, but you seem to be the complete DX RX package. So that seems awesome. Thank you for joining us. And what's your favorite thing to do outside the bubble of medicine?
Probably watch movies. I'm a big movie buff. Rochelle can attest. I make her watch all the movies I have on my list.
Well, does she make you play Risk?
No, we haven't played before. We have Risk at my place, and she knows that. So I don't know why she hasn't forced us to play yet.
Look at that. See, connections through VMR. Even people who know each other get to know each other better on VMR. Amazing. Well, thank you for joining us. And I see DXRX EDU is here. Hello. Good morning, Reza.
Good morning. How are you? How is everyone? Sorry for the delay. I don't know if we have a case or not. I just finished morning report here and ready for another one.
I don't know if I can publicly say someone's word for 2 lunches back to back, but we should have an equivalent for 2 cases back to back. Rez, I think people are picking up on something in your background in the chat.
Oh man, I have like 2. I know they're not picking up on this, but I can't wait to put this poster up. It's gonna go up today. And I have one more poster, Robbie. I thought about you for this poster. That's Robbie.
I appreciate that, though. I think that is literally the hallmark of Aaron Berkowitz. So I will take half of that poster because I love Einstein a lot. But I think EMT squared is totally Aaron Berkowitz territory. We actually don't have a case presenter yet. So if you are on the fence about it, please, you can pretend like you're sitting on that beautiful mustard couch that is the highlight of Twitter and VMR sessions. So I'm going to pause for 30 seconds and grab something to nibble on while we hang out. And we'll be praying and hoping that we have a friend to present a case to us. Be right back. All right, y'all. Woo! Sonia, I have to say, every time you've said that or a version of that, it's been quite a doozy. So, yes, I agree with Rafa. Go ahead, please.
All right. Can you guys hear me?
Absolutely. I think we should hear your magical case and then have Prof. Rez lead us through the first aliquot if he's cool with it. Sound good? Okay, perfect. I would just eat chocolate at 9 a.m. in the morning.
Chocolate is the best. All right. So This is the case of a 50-year-old lady who comes in for sort of routine follow-up in rheumatology clinic for a history of ILD. But she is more acutely dyspneic than she was before. And so I can stop there.
Yeah, I think that's thank you, Sonia, for volunteering, and very excited to tackle this case. Maybe what I could do is talk about the dyspnea, and then Robbie, if you don't mind pulling up a few of your schemas on ILD, because I think it'd be really helpful for us to see that basic approach of environmental factors, just primary ILD being IPF, and then ILD associated with rheumatologic conditions. But seeing that framework I think would be really helpful. What I can tell you is this, is when you're approaching dyspnea in anyone, you should start with the basic approach of heart, lung, and other. But in this case, you have to take into consideration the background of interstitial lung disease. Robbie will jump more into the various types of ILD and what workup this patient exactly had to, obtain this diagnosis. But regardless of type of ILD, the question becomes, are we dealing with something related to the ILD or separate from the ILD or a combination of the two? And when you say, are you dealing with something related to the ILD, then you can even break that down further into a flare of the interstitial lung disease, a complication of the medications used for the ILD, if any, especially if you have immunosuppressive medication, then you can start thinking about infections, including opportunistic infections. And then finally, you can think about the sort of architectural changes that happen to the lung and what they might predispose a patient to, for example, pneumonia. So to just take a step back, I think it's great to question what type of ILD this patient has, but regardless of the kind of ILD, think of causes of dyspnea not related to ILD, and then think of causes of dyspnea related to ILD being the flare of the original process or a complication of the treatment or an association of disease with the original ILD. But would love to pass the mic to the mathematician to break it down even further.
Folks, you may ask, what are, you may be wondering, is that a schema or not? And you're seeing that the kind of approach that Reza just outlined is an approach that is so critical not to go wrong, because his approach is all encompassing, yet said in essentially three branches. He's saying, is this a complication of ILD? Is this a complication of treatment of ILD? Or is this an independent disease process? And believe it or not, that is actually one of the most important schemas, the initial schema for the case. And I think I will dive into one of those branches, is what is the ILD here, and how could that change the landscape? And when Prof. Rez asks, you deliver. And so here is a very I'm merely a DoorDash delivery person for Prof. I'm kidding. The overall map for ILD is to ask three simple questions. Does the disease originate from the outside, like smoking or hypersensitivity pneumonitis? Does it exist from the inside, or do we not know? We don't know where IPF or idiopathic pulmonary fibrosis comes from. We don't know where sarcoidosis come from. There are many theories. In terms of what could be happening from inside, the most common cause is rheumatological diseases, but there are immunodeficiencies like CVID, and there are some genetic diseases that can cause interstitial lung disease. And Han presented one actually of a telomerase deficiency a long time ago that was an ILD. So given that this patient is in rheumatology clinic, we probably will be assuming that it is rheum, but that's not a great assumption to make. It's not perfect. It's not perfect because you can actually get drug-induced rheumatological conditions. You can also get pneumococces-induced rheumatological conditions. So that map is messy. But it is a reminder that patients with rheumatological conditions can first present with their lung disease, and that can be the end of their presentation, or they can go on to develop more overt classic autoimmune disease phenotypes after presenting with lung disease. I recently heard of a patient who actually had rheumatoid arthritis present with nothing rheumatoid nor arthritis for the first 3 years of his illness. He presented with lung disease and 3 years later developed classic RA features. And it was actually predictable because his CCP was positive when he first presented with ILD. So stories are often told in reverse order, and sometimes diseases read themselves backwards. So here it seems like we're dealing with possibly a rheumatological condition, but our map should be, is this a disease? If we're being strict about this, is our disease from the outside, inside, or do we humbly recognize we don't know? I'll share the deeper landscape of rheumatological disease with you briefly, just so we have this roadmap in case it comes up in more detail. Autoimmune lung disease, or ILD from rheumatological disease, is more complicated. And if it's systemic, which is what we're talking about, it could be vasculitic or non-vasculitic. Non-vasculitic is namely RA or myositis, or the 3 S's, which are scleroderma, Sjogren's, and lupus. And there's some other ones too. So this is not what I think we need to focus on now, but rather a glimpse into the possible future given Sonia's expertise in rheumatology. All righty, back to you.
Okay, so the patient, when she came in, was saying that she hadn't been to clinic in some time because she'd been just sort of nervous of follow-up, generally speaking. With the pandemic, she'd been trying to stay away from folks. She'd had her vaccine, but hadn't had a really good antibody response to it. So she'd been trying to kind of stay away. And when you ask her a little bit more, she says that, well, everybody's always told me that my lung disease is from Sjogren's, but nobody was fully clear on like what to do about it. She'd been tried on a couple of different medications, but the last was probably about a year before she came back to clinic, and that was rituximab. She felt that after she had the rituximab, it had improved somewhat, but now over the last 2 to 3 weeks, she feels like her dyspnea is getting a little bit worse. She is at baseline dependent on oxygen, but she has felt like the oxygen isn't really helping her feel less dyspneic when she uses it. And she's also had a couple of weeks of chest wall and abdominal pain. She's been coughing up some phlegm. She had recently been diagnosed with pneumonia that she'd gotten a full course of antibiotics for, and hadn't really thought much of it, but wanted to just kind of ask as a, well, could this be related? So I'll leave it at that for now.
This is super, super helpful information. And, you know, maybe what I can discuss is just the additional foreground data that you've given us and leave the background data of the ILD and Sjogren's for Prof. Res. And I think the foreground data clarifies that the tempo of this disease process is a little bit more subacute to chronic. And what does it do? I think it makes the common things that we worry about much less likely. So, for example, this is not a case of community-acquired pneumonia. What else can we say? We can say that, hey, there are a couple of features that we should put on the side of this case, and those features are chest wall pain and abdominal pain. It's not uncommon that, especially if the amplitude of these complaints, chest wall pain and abdominal pain, is not severe, they may not be satisfactorily explained or definitively explained. We may invoke the diaphragm and irritation of the diaphragm, or we may invoke irritation of the anterior pleura to explain chest wall pain or abdominal pain, but there are things to explore, but not be fully committed to given their relative amplitude compared to dyspnea. That being said, we've talked about chest dyspnea and abdominal pain more commonly than we've talked about how chest wall pain changes the calculus. And remember that we're talking about connective tissue diseases, and it wouldn't be unheard of for her chest wall discomfort as a part of a rheumatological condition to reflect sternoclavicular arthritis, for example, or costochondritis as part of a cartilage disorder. So you shouldn't completely minimize chest wall pain, especially if it is in the context of a rheumatological disease, because just like your hands and your feet and your back, you have joints and bones and cartilage in your chest wall. And so they may actually afford a clue as to what's going on. So not super dominant because of their relative amplitude, but something to definitely keep on the periphery of this case. Oh, and Nilayan, thank you for mentioning that. SAPHO is a great example of a condition that actually affects the lungs and also affects the chest wall. All right, Prof. Rez, mic to you.
Yeah, that's phenomenal. And I think what's important here is not to predict the final diagnosis because it would be impossible to. Of course, we need much more data, but it's to try to understand what the patient has been labeled as causing her interstitial lung disease. And this patient's ILD is thought to be related to Sjogren's. It's going to be crucial to understand what's causing the ILD because maybe the presentation is a flare of that inside job that Robbie so eloquently shared in his schema. So what to do now, honestly, is you pull up the illness script for Sjogren's and you review the chart to see how was this patient diagnosed with Sjogren's syndrome. And then to note that Sjogren's has many extra glandular manifestations, including the lung, including the liver. So I think really what my next steps would be prior chart biopsy, seeing that this patient accurately get diagnosed with Sjogren's syndrome. Because if so, then when I form that problem representation of the who, the when, the what, the who, I would include Sjogren's and I would consider other extra glandular manifestations that they might present with. And if we are worried about a rheumatologic condition and someone comes in dyspneic and has chest wall pain, you have to consider a hypercoagulable state and thromboses like a pulmonary embolus. So where I am now, it seems like she hasn't received Ritux, which depletes the CD20 positive B cells, making you immunoglobulin deficient and at risk of all sorts of infections. But I think the next step is to just obtain more history, look at the physical exam, and to go from there. By the way, Sonia may not have all the prior data regarding the diagnosis of Sjogren's. So you almost have to separate this into two separate problems. And at the foreground is immediately treating the patient's dyspnea, trying to diagnose it, while, on the background, looking up the prior information to see if it's correlated. So two different problems altogether to solve here.
Okay, so with that, we had a couple of records, a little bit of information about that past medical history you were asking for. Other than the ILD, she had known heart failure and was on a diuretic for it. So in addition to her diuretic, she took 2 antihypertensives, mycophenolate, and then the rituximab that we had talked about. She had no medication allergies that she knew of. Nobody really in the family had ever been ill. And she didn't have any significant health-related behaviors contributing to her medical care. Notably, she'd never been a smoker. So when we saw her in the clinic, initially, she looked pretty uncomfortable. Her temperature was fine, but her heart rate was 110. Her blood pressure was normal, but she was breathing 26 times a minute. And when she tried to get up onto the exam table, her oxygen saturation dropped to 83%, even on her supplemental O2. Her HEENT exam was notable for dry mucous membranes without any lymphadenopathy and without any swelling in her parotids. And her cardiovascular exam, other than the tachycardia, was pretty unremarkable. Listening to her lungs, though, she did have bibasilar crackles, and they extended up to the mid-lung without any wheezes or rhonchi and without any dullness to percussion. Her chest wall was quite tender on the left, really in the midclavicular line along the line of the rib. But her abdominal exam was completely benign, soft, non-tender, non-distended, no rebound or guarding. She was neurologically intact. She didn't have any skin lesions or rashes. And her MSK exam was not notable for any synovitis or any joint manifestations. And I'll pause there.
Wow, this is awesome, Sonia. Robbie, since you commented on the chest wall tenderness and brought up the possibility of chondritis, I'll leave that specific finding for you because it's a unique finding. and I will just focus on the vital signs and some data that isn't present that is quite helpful. First of all, I think if I was the examiner of this patient, I would be nervous. Like with little movement, this patient became significantly hypoxemic. So already in my mind, as much as I want to jump into diagnoses and know exactly what's going on, I'm thinking about stability and where should this patient be? And it's obvious that this patient should be referred to the hospital because they are in a CT deficient state of their lung parenchyma and parenchymal vessels. So that hypoxemia with the bibasilar crackles sort of localizes this patient's pathology to the lung and then probably sites outside of the lung. So when you have crackles, you can think about water, pus, blood, interstitial disease, and atelectasis. In this specific case, we know that this patient has ILD. The question becomes, has that ILD worsened, or is there a complication of that ILD like a pneumonia? So at this point, Sonia is going to be moving pretty quickly to refer this patient probably to the emergency department to get additional workup. And of that workup, I think the most important thing is going to be CT of the chest, hopefully with contrast, assuming the kidney function is okay to better evaluate. But Robbie, would love to ask you how you would approach the more unique finding of this case of chest wall tenderness.
Yeah, I think that's a great, well, one, I think that definitely this is a case of RxDX EDU, not DX Rx EDU, because you got to treat before you do anything. And I love that very simple explanation of the importance of that. I'll tell you what I think, but my confidence level I'm about to say is not to the level where I would use it in real life. But take the opportunity to practice it in this case. The first caveat, there are two of them. The first caveat is I don't think that I would have the knowledge structure to actually palpate this patient's chest wall in real life. I think if I were taking care of this patient and I saw that their SAT is 83% on the air, even if they had told me that their chest hurts, I probably, in the absence of trauma, would not find that to be productive. And so I'm so curious about where that's going to go because it might literally change my practice. But at bare minimum, it'll allow me to expand my knowledge on what this represents from an expert in the field. And but what I can tell you is what I know, and I'm telling you what I know only with some vulnerability because I don't really know it that well. But if I expose myself, then I'll be able to learn better going forward. And what I know is I lump all the joints in this area into all the joints and cartilages and essentially autoimmune diseases into thinking about the three categories that can cause disease here. I presented a case to Reza on RLR, which he dissected massively of septic sternoclavicular arthritis. So septic joint disease definitely causes chest wall pain and tenderness. And if somebody is sick, even though they're not sick from an inflammation perspective, you should think about it. The other thing I've seen is crystalline diseases causing arthritis of the chest wall. Namely a case of pseudogout that we had very recently at the San Francisco VA. Now, those are the two that I've seen. I've seen septic disease cause chest wall pain. I've seen crystalline disease. But the rest is I've read about, and I've read about the spondyloarthropathies having a propensity to affect the chest wall. And this is the gap in my knowledge is to what extent. And the spondyloarthropathies are the primary spondyloarthropathies are ankylosing spondylitis, psoriatic arthritis, IBD, and reactive. But there's also secondary spondyloarthropathies that look a lot like those spondyloarthropathies in the joints and bones they affect. And they are, as Nilan mentioned, a bunch of names that we'll just put up here for you to view should the case coalesce in further detail to allow us to study them more closely. So I'm not going to say them out loud because I don't know the space too well to actually narrate this world independent of actually looking at the schema. So I'll just do the same with you. And just so I've shared it with you all, this is the more proximal. Well, actually, I closed it already. But if you're thinking about chest wall arthritis, it's septic, crystalline, or spondyloarthropathy. And remember to divide the spondyloarthropathy into the primary and the secondary. I have no idea if this is merely detection of noise in a patient who's short of breath and been coughing a lot, and that's why her chest wall hurts, or rather a subtle clue to esoteric pathology, and only an expert can really tell you that. So I'll pass the mic to said expert to give us more.
Well, I agree with you guys completely in your thought process. And we were quite worried about this patient. So she went straight to the ED for an expedited workup to get a better sense of what was going on. So I can give you some initial labs and basic imaging, and then we can talk about what else happened while she was admitted. So her initial white count was 15.5 with a neutrophil predominance. Her hemoglobin and platelets were normal. And her BMP was unremarkable. Her COVID PCR was negative. And her coags were normal. So she ended up getting a CTA of the chest with contrast. And the CTA did reveal known ILD, so a very similar looking process to what had been seen on prior scans. There was no PE noted. However, there was a mass-like opacity, which was somewhat progressed from prior studies. And it wasn't fully clear what this opacity meant, but looking back at the scans, it had sort of been there for a little while, and it had initially been attributed to her ILD. But the current read from the radiologist was primary lung cancer ought to be excluded as a diagnosis because of the speculated appearance of the nodule. No lymphadenopathy was noted, and there was a UIP pattern on the CAT scan. So I'll stop there.
Oh, yes, that's right. Finally, something we can have confidence about in discussing. And so, yeah, I'll just ask one clarifying question. Is the mass located over where we could feel the patient's discomfort, or was it?
It is.
Okay, all right. So I think we can make the inference that what we're probably mushing on is this mass, unless there's a disconnect between those two anatomically. But, honestly, I'll leave the imaging studies for Reza to dissect, and we'll study the labs and say that I'm a little surprised this patient has a neutrophilia given the subacute nature of this presentation. And it goes to show you how humbling this disease process is. And almost no matter what, you can say this is an immunosuppressed patient with evidence of inflammation and an alveolar disease process. So I think that while in our hearts, we may not think this person has community-acquired pneumonia, I think it's too morbid a diagnosis to not entertain. So I think I would support anyone on the front lines in the ER giving this patient antibiotics, and would probably be inclined to do that myself. But I think the subacute nature, the background history of ILD, the immunosuppression, and this mass-like consolidation probably makes that diagnosis of community-acquired pneumonia at best an additional thing amongst all the chaos that's happening to this patient. It does not explain most things, but it's hard to argue against white count of 15, hypoxemic, tachycardic, immunosuppressed, against treating that. But I think it would be naive to say that's explaining everything, at least with confidence. So I'd be giving the antibiotics to this patient knowing that that's maybe not at all part of the story, or at most a small part of it. And for the rest, I'll pass the mic to Prof. Renz.
Well, you're too kind, Robbie. I'm going to share a very simple schema to lung mass, but I'll say something that's really important. And that's what Sonia shared with us in her presentation. And when that is this, the following is very important. Whenever you see a mass anywhere, but especially in the lungs, look at prior imaging. This is crucial because the rate of progression influences your differential diagnosis. So Sonia looked at the prior imaging, and we know that there has been progression, though we're not sure how fast this mass has progressed. And remember, if you think about skin disease as you have petechiae, purpura, ecchymosis, it's a spectrum, right? Lung mass is the same. It starts with the nodule, And then if it gets beyond a specific size, it's referred to as a lung mass. And then you can look for the quality and characteristics of that mass. For example, is it cavitary? Might be helpful. Is it spiculated? Is it calcified? So you can dive deeper and deeper. But whenever you have a lung mass, you really have to ask the question, is it infection? Is it malignancy? Is it autoimmune? Basically the same I made mnemonic, those three first letters. And when you discuss infection in lung mass, one possibility is an abscess. And Robbie said that you have to, treat this as sort of acute bacterial infection. That's less likely based on the description and the long-standing nature of this mass. But the infections you really need to consider here are atypical infections. Like, could that represent a tuberculoma, like mycobacterium, or fungal disease, histoplasmoma? So I think mycobacterial disease, fungal disease warrants consideration here. And if you ever are worried about that, then you should isolate this patient. And the good news about mycobacterial disease is that if you have a mass in the lung and you check a AFB smear, you should be able to detect AFB because the disease is in the lung. But if we go beyond infection, and cancer came to mind, this is when the who, the when, and the what. The focus right now really is this lung mass and the hypoxemia, obviously, that this patient has. So when we're thinking about the lung mass and we're applying our problem representation, this has been sort of subacute to chronic. It's not in a suddenly present lung mass. And the who, you have to presume Sjogren is present, because if you assume Sjogren is present, it increases the risk of a lymphoma by 30 times. Here you may say, well, there's no thrombocytopenia, there's no B symptoms, this is probably not lymphoma. I would caution you, because remember, we're dealing with someone who has an autoimmune disease, who's on immunosuppressive therapy, and you can still have lymphoma without a thrombocytopenia. So I might actually send an LDH as like a rough surrogate and be open to that possibility. And then you have to worry about all the primary lung cancers, which are broken down into small cell lung cancer 15% of the time, and then non-small cell, which include adeno, squamous, and large cell. Of all of those, only adenocarcinoma, you don't need any smoking history to have adenocarcinoma. For all of them, smoking increases the risk. And then finally, our autoimmune category, the two that I think of, and then I'm going to actually pass it back to Robbie because he has a more extensive list. I think about sarcoidosis. I think about GPA. And I think about rheumatoid arthritis. And we know, again, going back to the who, the Sjogren is associated with some autoimmune conditions, including rheumatoid arthritis. So we're not getting that flavor of joint disease, and there's no flavor for GPA. So then the lack of clues on history, physical exam to point towards another autoimmune disease puts me back at either a cancer, specifically lymphoma, or an atypical infection like a fungus or a mycobacterial organism. But Robbie, let me give the mic to you, my friend. What else would you be considering for this lung mass?
Oh, I don't have anything to add. I think that's spot on. Yeah, nothing to add at all. Zero, as I haven't said in a long, long time.
I was thinking about the schema you shared in Geneva, but okay, thank you.
Wait, which? Oh, yeah, yes. So no, thank you for reminding me that in the schema we had a nice, a really nice case of a patient who actually it's too long to summarize, in which we taught the concept that not all masses are malignancy. And that schema is long because there are a lot of benign causes of what looks like masses, and most of them are in the abdomen. That's things like endometriosis can collect into a mass, a splenosis, gallstones can fall. But I don't think I have any that are in the chest that actually can cause a mass. I think you nailed it all. But yes, you're right that there are many non-malignant causes of mass, but the kind of crazy ones usually show up in the belly. There's probably just much more room in the belly. All right, Sonia, back to you.
Okay, so now that we have the RX down, we can think a little more about the DX and dive into her past medical history a little bit. So she gets admitted to the hospital. She gets a little bit more supplemental oxygen. She gets started on high flow with some improvement in her hypoxemia. And then she has a bunch of rheumatologic tests and a bunch of infectious tests. So from a rheumatologic perspective, her RF and her CCP are checked and are normal. Her ACE level is checked and is normal. Her ANCA panel is checked and is normal. She has a negative ANA. She has negative antiphospholipid antibodies. And then from an infectious standpoint, she has strep and Legionella urine antigens, which are negative. She has an Aspergillus antigen, which is negative. She has a respiratory viral PCR, which is done and is negative. HIV, RPR, and hepatitis viral panels are negative. And she also has a histourine antigen, which is negative. So with all that, the decision was made to try and pursue a tissue diagnosis because it was really unclear what was going on. And there was a lot of back and forth about the best way to do this because of where the mass was located, whether to go in endobronchially or whether to go in through the chest wall and try to do a percutaneous biopsy. And actually looking back at the imaging, the area where the mass was actually invading into the chest wall. And so the thought was that perhaps this would help to keep the lung inflated while the percutaneous biopsy was being done. And so she did undergo a CT-guided needle biopsy. Those results took about a week to come back. And I'll stop there and let you guess.
You know, thank you for leaving that juicy bit to the end, because I think as soon as you put invading the chest wall, I think that certainly ups the ante and changes the calculus about the range of benign possibilities this could be. I'll leave that for Prof. Rest to reflect on, and we'll kind of take on the labs. And I think that the value of serologies, and especially, let's just talk about them sequentially. So rheumatoid factor is positive in 70% of patients with RA and 70% of patients with hepatitis C. Every other disease that you've associated with RF positivity, like sarcoidosis, like lupus, like endocarditis, only a minority of patients have disease positivity. So the RF and CCP together in the lack of arthritis makes RA much less likely. ANCA is a very helpful test, especially in granulomatosis with polyangiitis, in which it's positive in up to 90% of patients with systemic disease. But a negative ANCA doesn't exclude MPA or EGPA, both of which are unlikely for other reasons. The ANA negative is actually a feature of many autoimmune diseases, but it makes the three predominant ANA positive diseases, namely mixed connective tissue disease, scleroderma, and lupus, which are you should expect to be ANA positive in over 90% of patients, much less likely. So here you probably would stop and say, wow, is this RF negative, ANA negative Sjogren's? And you would wonder about how confident the diagnosis of Sjogren's was. It's possible to have ANA negative, RF negative Sjogren's with your classic serologies being SSA, SSB, in addition to biopsy and symptoms. But the reason I think it's so important to scrutinize Sjogren's, because I completely agree with Reza. If you present a case of patients with Sjogren's, a patient with Sjogren's who doesn't smoke, who has a lung mass, it's a pulmonary lymphoma until proven otherwise, especially if it starts to invade other territories. So really, in order for your other leg to say pulmonary lymphoma, your first anchoring leg should say Sjogren's confidently. So for me, I would be probably looking down at my right leg and saying, how confidently, how well is Sjogren's spelled there? And if it's not spelled well at all, then pulmonary lymphoma plummets. But if it's a confident diagnosis of Sjogren's, I would firmly be in the, a mass can be anything. It's hard to exclude infection, and Anne-Marie has ectino in mind, but I'm really now with the serology saying, is this Sjogren's or not? And I would just emphasize that Sjogren's does not have to be ANA positive and does not have to be RF positive. So it's very possible, but it would have been way more probable if the RF were positive and the ANA were positive. Alrighty, I'll pass the mic to Prof. Rez for his concluding thoughts.
Oh gosh, zero to add. And I really loved your framework and Anne Marie's comment about actino, because now we're using the characteristics of this mass, meaning that it's going beyond its territory. It's a mass that is aggressive, a mass that's invading beyond its birth region. And something else that comes to mind when I see stuff like this that are aggressive are sarcomas. So could this be some form of sarcoma that's coming to light? But if I had to put my money down, I just don't get much of a systemic flavor for infection, despite this patient being on immunosuppressive therapy, but it seems like they haven't received it in some time. So infection, I want to put that lower, despite actino being one that can cause aggressive invasion. And right now for me, I think this is most likely going to be some form of cancer. Lymphoma, if Sjogren's. If Sjogren is inaccurately diagnosed, I'd be worried about also a sarcoma. And then I did a quick Google search, and some primary non-small cell lung cancers can invade the chest wall, but not to the point of, well, maybe to the point of coming on the skin, but I think that's less likely. The only cancer I've seen actually that present on the skin has been a plasmacytoma in the context of myeloma. But anyways, I think tissue, there's no way for me to accurately predict. There's no rush to put this patient on long-term, antibiotic therapy. So you wait for the tissue diagnosis and go from there. And one last thing, I don't think the mass is explaining the hypoxemia here, folks. I mean, we would have to see the imaging unless it's really large. I'm just worried that this ILD has progressed, and that's a different problem and different management than necessarily this mass. So I don't know how much to blame the worsened hypoxemia on the mass, unless the mass is something that's significantly large, impairing, oxygenation. Do you agree with that, Robbie?
Sorry, I was schema diving. I completely agree with that. I completely agree with that assessment. I think we come up with that thought all the time, where one focal brain lesion shouldn't cause encephalopathy, where one kidney is down shouldn't cause AKI, and a focal mass like that shouldn't cause this degree of consolidation, this degree of hypoxemia. Completely agree. It might be because her UIP is that bad, her ILD itself is that bad, but why it's worse, again, is a question that we don't have answered. But yes, it's definitely something that is a problem that's not fully tucked in my mind. All right, Sonia, the time for the reveal.
So I will fill in a few of those gaps for you, and then I'll let you know what the biopsy showed. This patient did have very extensive ILD. So looking at her imaging, the honeycombing really was affecting I would say like 75% of both of her lungs. And discussion of transplant had actually come up in the past, and was breached also at her outpatient follow-up appointments. However, her more acute picture kind of took over her care before we could get too far down that road. When we reviewed the radiology, we didn't really have a clear answer as to whether or not her ILD looked worse than it was before. She'd had sort of a slow progression over the past maybe 5 to 6 years, but it wasn't fully clear if what we were seeing was entirely worse or if this was pretty similar to her last scan about a year prior. It was really just the mass that was new and different. And so on that CT guided biopsy, we saw a poorly differentiated adenocarcinoma with mucinous features. And unfortunately, after having the procedure done, the patient did develop a small pneumothorax and decompensated from a respiratory standpoint. So she ended up needing to be intubated and went back to the ICU. And over the course of the next week or so, her course was also complicated on top of that by a pneumonia, a ventilator-associated pneumonia, unfortunately. So she had difficulty coming off the vent. She wasn't really able to breathe on her own. And discussion was had with the patient and her family as to what the next steps were, because while the biopsy data was pending, we were concerned certainly about a malignancy. And that sort of changed the direction of the conversation as to her long-term versus her short-term care. So the patient and her family decided that they wanted to maximize what time she had with them as much as possible, if possible at home rather than in a facility. And so the goals of her care changed from definitive curative treatment to maximizing any chance she had of getting off the ventilator so that she could spend time with her family. She did eventually pass away in the hospital, but she was surrounded by family and friends who were able to make it in from out of town and support her in those moments.
Sonia, this is a very, very humbling case. So thank you for, especially when the prognosis of the patient looks as dismal as it is, coloring it with the efforts of the team and of the family to be there with her in her final moments. Yeah, I think this case is very humbling in many ways, and I think reinforces the teaching that Reza gave us about adenocarcinomas that can occur in patients who don't smoke. And I think I know you're at the VA, so you probably can't share that schema. Is that right, Rez? You can't, I don't know if you can pull it up and share it, but I think that the journey that you took us on is really outlined in that schema so well. But yeah, I think this case is very, very humbling. It also keeps you on your toes as a discussant in these VMR cases where you shouldn't assume that a rheumatologist is presenting a rheumatology case necessarily. And I absolutely love that. Maybe while Reza's pulling up the schema, Sonia, do you want to share what wisdom you took from caring for this patient?
I think the biggest thing I learned was that, especially in rheumatology, some of our diseases have really great treatments and we can get people into remission and we can really get them feeling well. But a lot of our diseases don't, and a lot of diseases that are associated with not our diseases don't. And so the biggest thing that I took from this case was really being able to support a patient with a dismal prognosis and be there for her and her family when there's not a darn thing I can do about it.
Sonia, thank you so much. I think your emotional intelligence is only matched by your intellectual intelligence. This was very instructive of a case and a very nice touch at the end. And I'll just leave this up for 1 minute. You guys can access this on the website. And it just tells you a schema-based approach to lung cancer. And I think though, the key here is knowing to qualify that mass as an invasive mass. And then lung cancer is probably the top of the list. And then Googling and saying, hey, can this lung cancer cause invasion? And then you'd probably make more progress on that. So don't shy away from certain characteristics. Be okay with saying, I don't know, and then test your hypothesis using some form of search engine. Mike, to our teacher.
Prof. Rez, our teacher is teaching for the very first time. Marcella, we're so excited for you to do this. And I think that today will set an incredible benchmark for you to keep track of going forward when you do this many more times. But we're all rooting for you to crush it and excited. I actually saw your teaching points before you're delivering them now. I think they're superb and I can't wait to hear you say them out loud.
Oh, thank you so much. And thank you so much for this case, Sonia. It reminds me of the first case I presented on Septic. It was also an adenocarcinoma, and sadly, the outcome was the same. It's really aggressive. And thank you so much for the discussion. It was amazing. So let's go for the teaching point. We saw that dyspnea. We should start with the basic approach. So think about heart, lung, and other. But in this case, we need to consider the background because the patient had ILD. So you need to think if it's related to the ILD, it's a complication, or it's because of the treatment, the patient's immunosuppressed, or is it an independent process or a combination of both? So we learned too that ILD, interstitial lung disease, it can be from outside, like smoking, drug, radiation, heavy metal, hypersensitive pneumonitis, or from the inside. Is it a rheumatologic disease? Is it immune or genetic? Or is it a idiopathic process? So it's important to understand the origin of the ILD, because if in this case, is it related to the Sjogren's disease? It can be related to the present presentation. So we should go back and review the patient records because it can change the who, the when, or the what. We also saw the tempo is key because it was a subacute or chronic process in this case, so we can exclude common causes. And this patient also had chest pain and abdominal pain. It was not dominant, but it could be the part of the rheumatologic disease. For example, the joint disease that Habib told us. So an infection could be a septic disease or a crystal disease or an spondyloarthropathies. We also saw that the vital signs were concerning us. So first you need to stabilize the patient, then you need to think about the diagnosis. We saw the patient had crackles, could it be water, pus, blood, or cells? We were thinking about community acquired pneumonia because it's a diagnosis that we cannot miss, but we saw that it does not explain everything about the case. So it was really difficult to exclude. So give the antibiotics and then keep looking for another diagnosis. And then we finally saw the mass on CT. And Reza told us that we need to look at previous image and look for the progression to see if it's in a case that it's evolving or not. So we can use the first three letters of the IMA mnemonic. Is it an infection like an abscess, an atypical infection like TB, fungal disease, or is it a malignancy like in this case? And to think about the malignancy, you can go back to who, when, or what. If it's Sjogren's disease, it could be a lymphoma, or it could be an adenocarcinoma, a small cell carcinoma that can also invade the chest wall, or a sarcoma. Or is it an autoimmune disease like GPA or rheumatologic arthritis? We saw that the nodule is going to progress to a mass, and you need to look at the characteristics to find if it's an infection, malignancy, it can help you. Finally, we saw the serologies, NNA and NANCA. It can help us to exclude some diagnosis, but Sjogren can be NA negative and ANCA negative. So we cannot exclude Sjogren based on that. And in the end, we saw that that mass could not explain the hypoxemia. So you also need to think about another process. Is the ILD progressing? So that's it for today. Thank you so much. I'm sorry if I missed something because we had a lot of many good teaching points. Thank you so much.
Marcella, that was brilliant, truly. Masterful teaching. And you were kind to us too. Thank you. Thank you for making us feel good. Is Rafa, anything happening tomorrow? Rafa or Robbie?
Yeah, we have a special event tomorrow with the Brigham Sound.
What time, Rafa?
Oh, this time already. 12 p.m. Eastern time.
All right. Well, thank you all so much. Everyone have a lovely day. Thank you, Marcella. Bye, guys.